Thanks, everyone. My name's Daina Sturnieks, and I'm going to chair this session. I'm on the management committee of the network, so thank you to everyone for coming. Thank you for Tash for putting it together and the management team as well. I too would like to acknowledge the traditional owners of the land that we are very lucky to work and live in, and especially ahead of National Reconciliation Week, which starts next week. So hopefully we can all think about the types of things that we could do to help to reconcile our nation. And it doesn't have to be a big thing, it can be a small thing like having a conversation or reading a book or anything big or small to work towards reconciliation of our country. Okay, so I'm going to get going now and introduce our first, actually before I do, just a reminder that we do have that Slido poll going, or the question platform going, so you can log into there and ask questions. We may not get to them, but we are asking our speakers to try and get onto Slido and answer them for you. So apologies if we don't get to those questions, but we'll do our best. Okay, so our first speaker for this second plenary session is Professor Stephen Lord, who is a Senior Principal Research Fellow at Neuroscience Research Australia. He's published over 400 papers in the area of balance, gait and falls in older people, and is clearly acknowledged as a leading international researcher in his field. His research follows two main themes. That's the identification of physiological factors for falls, as well as the development and evaluation of falls prevention strategies. But he really has worked across the spectrum towards implementation as well. So, rightfully so, in December 2019, Steve was awarded the Lifetime Achievement Award by the President of the British Geriatrics Society in recognition for his contribution to falls research. The title of Steve's presentation today is Compiling the Evidence Base, the Research Landscape over the Past 30 Years. Thanks so much, Steve.
Thank you, Daina. I've actually taken a bit of a liberty, and I'm going back a little bit further than 30 years just to give the full context. So I'm going back to 1960 and to the work of Joseph Sheldon, who is really the grandfather of falls. Did his work in England, and he published a paper in the British Medical Journal, and you can see there that was my copy when I worked at St George Hospital from the library when they had their stamp on it. And if you look at his paper there, he's a number of comments that are worth looking at. Yet the liability of old people to tumble and often injure themselves is such a commonplace of experience that it's been tacitly accepted as an inevitable aspect of ageing and thereby deprived of the exercise of curiosity. And the literature on what has always been a trial for the elderly and has now become a problem for the community is very meagre. So not much was known at all. It's was the start of geriatrics in about 1960. So this is an attempt for what he did to actually get a grip on, trying to scientifically describe what are the causes of falls. But if you have a look at the categories, it's clearly pretty much a first attempt. So accidental falls, drop attacks, which have remained an elusive element in research, trips, vertigo, bad backs, postural hypertension, weakness in the leg, then falling out of a bed or a chair. So it's an attempt to actually try and nominate the causes of falls. So it's the first attempt. So he's drawn attention to the problem. So you think, well, that's a call for action. So what happened? And nothing happened until the next stage. So 17 years it took before the next paper was ever published on falls. So this was the initial studies, and in these papers it's following sort of like the sequence of just trying to get a grip on the size of the problem and then try and understand what might be the causes. So the retrospective studies that were undertaken back then, they were easier to do because you just looked at a range of possible factors that might predispose people to fall and then ask them if they fell in the last 12 months and look at what the factors are associated. And there, many of these were British, but Exton Smith, Peter Overstall, Grimley Evans, there's John Campbell there from New Zealand, Brocklehurst, and Bernard Isaacs, who did a lot of wonderful work in that period of time, and Blake. So that was the first phase, and it did document a number of factors that were actually came up consistently as risk factors for falling. And from this is where we get this figure of a third. So this is where we actually find out that a third of older people do fall, and the numbers of people who fall increase with advancing age above 65, so that it gets to 1 in 2 in people over 85, and the proportion of multiple falling also goes up. So it's clearly an issue for older people. The button's not perfect. Okay, sorry. And of course, with that, in terms of just falling, what does it mean in terms of injury? And this is falls admission rates that we know is increased exponentially. And this is data from New South Wales for some time back. But, the chances of falling and being admitted to hospital because of fall-related injury gets as high as 4% for men and about 7% for women by the time they get to 85 and over. And projections, this has been also important to do. It's not only been used in terms of documenting the problem, but also for advocacy to actually clearly delineate the problem. And this one really shows the issue of falls in related costs for falls in related to what we all know as other big factors such as road trauma, violence and self-harm. So it dwarfs the others and will continue to do so into the future. Okay, so moving on to phase 2. With more interest in the topic, we've now got to about 1988, and this was the golden period for the prospective fall risk factor studies. So these were the large ones, properly powered for falls, often with hundreds of people in the samples, and with careful documentation of falls into the future, usually with documenting falls weekly or monthly. So I'll just draw attention to 2. There was the definitive study by Mary Tinetti, which was published in the New England Medical Journal and was very influential. So this had a sample of 380 people or so, and she followed up people for falls and came across a number of risk factors for falling relating to balance impairment and a range of different medical conditions. And also the work from John Campbell was a larger study. I think it was 760 people or so. Similar, prospective in nature. It was nearly a whole community study near Dunedin, so a defined geographical location, and again, a very carefully conducted study to really determine what are the important risks for falls. I'm not going to go through this at all in any detail, but from this, we have a range of factors that have been identified across multiple domains in terms of risk factors for falls, and I've quickly just, 3 asterisks here would indicate found in many studies definite risk factor down to a dash in the case of alcohol consumption, the bottom one there. But a lot of psychosocial and demographic factors have been linked to falls. Medical factors, a lot of the main medical conditions that all impair balance, sometimes cognitive function. Medication factors, some of the so-called culprit or falls risk increasing drugs, the psychoactive medications ones in particular. Psychological factors, particularly executive functioning or planning, slowness, and also anxiety and fear. Sensory, motor and muscular factors, so this is starting to now look at the domains that we use, functionally rather than in a disease way, vision, sensation and our strength. And also balance and mobility factors. So these are more general measures of mobility, measurements of gait, standing, transfers, reaching and stepping. So all of these, lots of evidence that they all, if you've got an impairment in these, your risk of falling will increase. So that kind of looks daunting, but in a way it isn't, because for many of them, when you identify the risk factors, you've got a target. So you've got a target for actually trying to do an intervention. And many of these have indeed informed the interventions that became the next stage. I forgot environmental factors. These are much harder to measure because they're so transient and move, but there's increasing evidence for factors like inappropriate spectacles, home hazards, as also adding to the risk of falling. So this one I've put up, this is a quirky little study, clinical correlates of sway in old age, and this was my biggest influence. So this is what got me going in falls research. So this study that looked at body sway and as a summary measurement of balance, what predicts it? How do we stand steady? So how do we understand balance? And the thinking is if you can understand balance, you can understand what goes wrong when people have fall. And this goes way back to Sheldon again from 1963 in this time, when he developed a simple sway meter and he looked at sway across the lifespan. And you can see when you ask people to stand still, he's taken it right back to children aged 6 to 9 through to people aged 80 and over. And you can see how people get better and better right through the middle years and then worse again. It's very much a mirror. And the slide on the right indicates just how much sway increases when people have their eyes closed and the dependence on vision. So this sort of thing really interested me, and I thought there's scope here to look at things like sway and function, and this what was the inspiration for me to go to look at physical functioning rather than a disease approach to falls. So looking at vision, sensation, strength, speed, and measurements of balance. By looking at it in a functional way, rather than trying to find a cure for a disease, which is often not possible, to look to see if you could actually improve the function, whether it be strength, balance, vision, etc. And that moved on to a profiling approach where you could actually give everyone a documented score and with an eye just to test a single snapshot, see that this person's problem might relate to their vision, their strength and their balance, and give an estimate of their fall risk. So this was an approach that's also, not just this one, but underpinned a lot of interventions to look at trying to improve function across a lot of our physiological systems that we depend on to maintain our balance and avoid falls. I haven't got the swing of this button. It's hard. Okay, so the next phase, 1994, and it hasn't got an end, it's the interventions. And this is the number of publications we have in falls now. So to look back to 1960 when there was one and then nothing till 1977, we now have over 1,000 every year. So the battle now is to actually keep up. But not all of these are interventions, but many of them are. So there have been a lot of interventions since 1994. So these are just some of the early influential ones. So I'm not going to go through them all because there have literally been hundreds of them. But multifactorial interventions, doing an assessment, trying to identify multiple risk factors, intervene accordingly. Tai Chi, home exercise, the Otago exercise program, which is still very influential to this day. Multifactorial interventions in nursing homes, multifactorials for people who identified in the ED and then went home, by Jackie Close, inserting pacemakers to prevent falls for people who have a particular cardiac condition, and cataract surgery. So these were some of the early intervention trials that influenced the work to prevent falls. So that's the next step. I can't go into all of the ones, and many subsequent interventions have been undertaken, including a number from people in this room. Next step, from about 2000 and on, these figures are always a little dodgy, but around this time, there's been a lot more emphasis on actually trying to synthesize all this information so that it becomes more confident in the conclusions and more generalizable. So Cochrane is the key here. So Cochrane collaborations have the highest level of evidence. They're the strictest, most rigorous, most difficult to do because of all that. But if something gets recommended in the Cochrane review, you can be reasonably confident that that actually has been given a good test of scrutiny. And so these are the Cochrane reviews. And here's an example, one that's not a Cochrane, but it's related to it. It's the work led by Kathy Sherrington. And in this case, she looked at 99 comparisons from 88 trials to see whether exercise can prevent falls. So not going just from one, but now 99 comparisons, and subsequent iterations of this have increased it over the 100. So with all that level of evidence, you can really come down to some key findings. And I think this is one of the key ones. If you look at all of the evidence from all of those trials and you break it down to two factors, balance, intensity, and the dose, we find two things: that if you don't have either of those, you'll only prevent falls by 10%. and not significantly so. If you've got a moderate to high challenge to balance, and the exercise is for 3 hours or more a week of prescribed exercise, you've got a much larger 39% significant reduction. So that's where all of that work has led to this one slide. So that's how we know what to do in exercise, all that work, and so that's how the evidence has been compiled and where it ends up. And the next phase is implementation research, and this is a study that Kim is leading, just finishing up with now, for actually going beyond the RCT and working with the healthcare systems and healthcare providers to make sure an evidence-based program actually gets implemented into routine care. So that's the next stage. And then that all can end up in guidelines. And so this is the last iteration of the Australian Fall Prevention Guidelines, and I'm sorry to say it's from 2009, but the exciting evidence is they've just been redrafted and will be launched at the Australian and New Zealand Fall Prevention Conference in Perth in November this year. So they'll come out in 2023, 2024. So that's where they will all end up, as concise grade-related recommendations based on compiling all of this evidence that we've gone from all of these different phases. So in summary, this is the sequence. A lot of it's been done in the last 30 years, but it goes back beyond that. Actually delineating the problem, identifying the risk factors, conducting really good gold standard interventions, synthesising the results, and then implementing them into practice. But of course, when we get to guidelines, that's in a way just the start. That's just the end of the research phase. The next part is all about implementing and make sure it happens. So that's another talk, but that's the research phase. So thank you, and here's a plug for the conference that will be on in Perth at the end of the year. We've got fantastic speakers, so if anyone can come, you'd be most welcome. Thank you.
Thanks so much, Steve. We do have a few minutes for questions, so I'll open it up to the floor. There's microphones running around, but otherwise I will ask a question from the Q&A on Slido. Okay, while we get a microphone over here, Siri, please. Not from you. There's a question here.
From Siri.
Yeah. From Anonymous, alcohol, what are your recommendations around navigating this issue, given adults aged 50 and over are more likely to exceed lifetime risk guidelines?
Yeah, it's a really interesting question. It's lots of people, all of the risk factor studies were actually mostly done in the 80s and 90s, and I don't know of any big risk factor studies that's been done since then. But all of those looked at alcohol, and it didn't come out as a significant risk factor in those studies. And I think it's primarily a selection bias, that the people who take part in research studies don't drink too much in the first place. So I think that's part of the issue why we haven't found there is no doubt that alcohol is related to fall-related injuries in hospitals and so on, so it is an issue. It hasn't been the focus of my work or in fall prevention, but it's clearly the case, like I guess any other intervention, it's a difficult one, but to approach it through the health belief model and just bring it into a positive lifestyle.
How much do you think the fact that older people, shouldn't call them old, should I? Older people don't want to exercise is a bit like the talk we had this morning, in that people didn't want to look after their sun smart and they didn't want to stop smoking because they didn't understand. Have we almost lost the battle because we aren't changing people's attitudes to exercise in their 30s and 40s and making them understand that if you don't start this now, by the time you get to 60 or 70, you're really pushing the proverbial uphill?
Yes and no, I think. I think in some ways it's never too late, because we've got all this evidence from randomised controlled trials of people aged 70 and over, and it makes a difference. Can cut the rate of falls by 40%. If they've got the balance challenge. But yeah, I agree. Lifestyle change is key, and if you've got people who exercise from 30 on and maintain, it becomes part of a natural way of life and is important. So it's, if we can, for sure, but it's never too late as well to make a difference.
I like this question. Online. Where do you see fall prevention research going over the next 30 years?
Okay.
Last one.
The future, that's, I think there are a number of different things. So we've got to embrace technologies where we can, and there's lots of ways we can look at falls monitoring, maybe falls predictions through sensors. It's still to be done. Nothing works particularly well at the moment, although it certainly is under investigation. I think we need to look a lot more at adding task specificity to interventions. For example, reactive balance training, which is hard to do. You'll hear a bit more about that from Yoshio Kubo in this afternoon's session about how that can be done and how it can possibly scaled up clinically. Using, again, technology, whether it be tablet form in terms of iPads or other ways to actually embrace the technology. And a lot more, I think, in just terms of implementation research to actually make sure we can get evidence-based research from trials actually out in community settings, practices, so it actually, we can, an effect at the population level. So I think that'd be some areas for the future.
Please join me in thanking Steve for the lovely wrap-up of the evidence.